I think a number of things we touched on already, but I'd like to just highlight a few important aspects in terms of the management of high-risk disease. And I think the take-home message will be that there is a good deal left for improvement, obviously across the board in terms of any of the treatment options or strategies available. We recognize that the risk of local recurrences or biochemical failures, we've heard earlier today, is not optimal with surgery alone as monotherapy, not optimal with radiation alone. The combination approaches certainly are attractive, but even with combination approaches we use, it's still not good enough. And clearly the answer is going to be improving the systemic strategies that go along as adjunctive therapies with the local therapies. And certainly emerging studies or studies in progress are there which give us at least encouragement that these kinds of approaches may be promising ones in improving the disease-free survival outcomes for such patients. So in high-risk disease, certainly there are a couple of critical ingredients. Number one is that we need, at least as a form of therapy, be it surgery or, in this case, radiation, we need to make sure that we provide the appropriate dose intensification, which we talked about earlier this morning. We need precise and accurate ways of delivering those high doses of radiation, which fortunately technology is now available. And the use of androgen deprivation therapy certainly has been recognized based on level 1 evidence to provide improved disease-free survival and survival outcomes. And the real question is, what is the optimal duration of hormonal therapy? And could we use better agents that have less impairing quality of life factors for our patients? And I can tell you that, at least from my experience, trying to get patients through 2 years of hormonal therapy is not obviously straightforward. And the impact this has, as we all know, on overall fatigue, quality of life, muscle tone, but then even more so, the cardiovascular effects are recognized, the risks of any forms of dementia and the like really, I'd say, are concerning, and certainly concerning for the patients. And the question is, if we've improved our therapy so greatly, can we get away with shorter courses of hormonal therapy or more effective second-generation androgen deprivation tools that may be as effective or likely perhaps more effective? When we've looked at our patients, and this is just with external beam alone, we've talked previously about the combination of external beam and brachytherapy, but this is the highest dose that really anybody has used. And we've utilized this for over 1,000 patients with 86.4 gray. And in general, the high-risk group had hormonal therapy. In this patient population, it was for about a median duration of 8 to maybe 12 months. But despite all of that, the PSA relapse-free survival at 5 and 10 years was 75 and 65%. And again, these patients clinically did not have metastatic disease. And the question is, can we do better? And could we approach these patients with maybe more innovative approaches? Even when we look at surgery, and we've heard already, the risk of biochemical recurrence is at least the same as what we see with radiotherapy. In the very high-risk patients, we heard from Dr. Ladone that some of these patients have across the spectrum in our institutional experience of about a 50% PSA relapse-free survival. Yes, they could be addressed in some cases with radiotherapy, and in other cases, they may have micrometastatic disease already, which is not going to be helped. And we need better imaging tools to figure out who are the patients that truly have local regional relapsing disease that are good candidates for salvage, and which patients are not going to benefit from a local regional approach. When you look overall at high-risk patients, be it with combination of external beam radiation and brachytherapy or surgery, there are risks that range from, on the average, from about 40 to 60% biochemical recurrence. And so we certainly need to address it. And I think Dr. Hamdi had elegantly talked about some of the myths or misconceptions of the PROTECT trial, which I think will become clear with further publications. But this was a study that extracted the excluded patients from the PROTECT trial and looked at just the high-risk patients who were ineligible, so certainly not part of the trial, and also consistent with the fact that there were no significant differences between the radical prostatectomy group and the radiotherapy group. However, despite all of this, we recognize that across the board, whether it's radiation, whether it's surgery, we need better tools to work with our local regional therapies to achieve improved survival outcomes for these patients. So optimizing the use of ADT for high-risk disease, what do we know about it? Well, the phase 3 trials have taught us that it is the standard of care. It's our practice to utilize several months of hormonal therapy up front to achieve maximal volume reduction. If there is some volume associated, larger volume associated with the prostate, and then the concurrent ADT and the adjuvant long-term ADT has shown to be associated with survival benefits for these high-risk patients. When we look at this EORTC trial, and there have been attempts made to try to better understand which patients or what is the optimal duration of hormonal therapy. We would love to see that short-term hormonal therapy should do as well as long-term, but this study was not able to demonstrate that. And as a result, the standard of care or standard thinking in the radiation oncology community is that for high-risk patients, we need something more than 6 months. And other studies have emerged indicating that perhaps 18 months would be, from Canadian studies, would be as good and considered as an appropriate, somewhat longer-term hormonal therapy. And in this review, again, of multiple trials looking at high-risk disease and the duration of hormonal therapy, it was clear any kind of hormonal therapy is going to help reduce the risk of mortality in these patients, but the longer treatment durations provide an even greater benefit or magnitude of benefit. So what do we need to do if we're going to approach a patient from the radiotherapy perspective with high-risk disease? Not shown here, but we clearly need to stage the patients appropriately. Those patients who have gross nodal disease, I personally don't think are the optimal candidates to manage their nodal disease with radiation, and I do think that a surgical approach in those cases could be optimal, and that is an approach that I think needs to be studied on a larger scale basis. If we're going to treat the tumor with radiation, we've already pointed out that we need to utilize dose intensification. We need to have the appropriate duration of adjuvant androgen deprivation therapy, and that is probably what we choose for our patients, a course of total duration of 18 months. We routinely include the regional nodes within our treatment portal, and data from our institution looking at patterns of failure based on subsequent scans have found that if there are nodal failures, they tend to be found at the level of L4, L5. And interestingly, the classic radiation portal for the superior aspect will go to L5, S1. And so, and this is a point that Dr. Mac Roach has made on many occasions, that the encompassing the appropriate lymph node regions would be just as important as it is for the surgical template to have the radiation therapy template being as encompassing. And then I think what's most important and what has the greatest promise is the use of novel second-generation anti-androgens or systemic therapy or combinations of thereof to enhance further the local therapy and systemic outcomes as well. The RTOG has attempted to look at approaches like this, and there are many emerging phase 2 trials now looking at the second generation anti-androgens. In this particular one, the experimental arm was 6 cycles of docetaxel along with standard hormonal therapy. There are many such studies. I just chose one. This particular one from Duke, where unfavorable risk prostate cancer patients would be given Abiraterone and the standard hormonal therapy, this time for 6 months instead of the prolonged aspect, considering that maybe these more potent forms of hormonal therapy would obviate the need for the longer courses that we routinely use, and then giving standard course of a standard dose intensification of external beam radiation, 75 to 80 gray. And the endpoint here, not survival, it's a smaller study, phase 2, single-arm study, where the primary endpoint is an undetectable PSA at 1 year. We have had a real interest in combining with second-generation anti-androgens in the setting of stereotactic radiosurgery to explore the possibilities of improving outcomes, but first exploring it as just a safety study as well. Prior combination studies have shown us that, and based on in vitro data as well, that there could be an important synergy that exists between these anti-androgen therapy interventions and radiation. And the upregulation of the androgen receptor through DNA repair pathways in combination with ionizing radiation could actually improve not only tumor control, but improve as a result or a direct result disease-free survival outcomes as well. So in our disease management team, the PI of this study is Sean McBride. We are treating these high-risk patients or very high-risk patients with a combination of ARN 509, the apalutamide, abiraterone, and standard hormonal therapy with stereotactic hypofractionated radiation. This is the treatment regimen I spoke about earlier that consists of 5 treatments only, directed, it was decided, just at the prostate seminal vesicle level. And the purpose of this study, again, was mostly for safety, but also to get secondary endpoints as far as efficacy as well. The inclusion criteria are really patients that have 2 or more high-risk factors, so they have to have Gleason 8 along with a high PSA, or anybody with Gleason 9 to 10 disease, or larger volume Gleason 8 disease. And patients who've had, obviously, prior treatment, or TURP, or prior radiation would be excluded from this study. And this, as we've called the ASSURE study, we have several institutions, it's a multi-center study, phase 2, where the study design is that they get the abiraterone and the ARN 509, apalutamide, and the hormonal therapy, and then in conjunction with 40 gray in 5 fractions delivered to the prostate and the seminal vesicles. I'm going to conclude with, along the lines that Dr. Kantoff had spoke about, how we could consider using genomic profiling to predict radiotherapy response, but potentially select out those patients who may be good candidates for agents like PARP inhibitors to further improve outcomes as well. This is something that is generating a good deal of potential interest. We certainly don't know who are the patients who are the most likely responders. We clearly have some who have very incredible response to treatment with Gleason 9 to 10 disease, PSAs of 80 or 90 who decide to get radiation, and our long-term survivors. And clearly we need to identify who are the patients that who are the best responders based on genomic profiling. This is earlier data from William Polkinghorne, who was previously in our department, and looking at the AR transcriptional activity and repair gene expression across primary prostate tumors, not castrate-resistant disease. And you could see that there's an incredible variability and heterogeneity within AR transcriptional activity. And we certainly recognize as well with what has been published that DNA damage repair mutations have clearly an influence and potential influence in primary prostate cancers. Substantial portions of patients with primary cancers harbor somatic and/or germline genetic alterations. Small subset of patients with prostate cancers we know harbor germline defects in BRCA2. And with what we have available now to identify such patients with various DNA repair genes, and more than what we've recognized in the past, we may be able to select those patients who could be candidates for treatments like PARP inhibitors along with radiation. One of our fellows had looked at this from the TCGA cohort of primary prostate cancers, and seems that there is a correlation with the higher Gleason scores and the percentage of patients with DNA damage repair alterations. And when you look at here, you basically see this phenomenon as well across the board. And when you look at, in this cohort of 128 patients who had high-risk primary prostate cancers, which we've looked at from the TCGA cohort, the disease-free survival differences, whether they had any form of a DNA repair alteration, was associated with significant improvements in disease-free survival, suggesting that this could be not only prognostic, but it may be a way that we can select these patients out and take advantage of this approach. And so there are a number of approaches, I believe, that are in progress, and we're certainly initiating some of these in the very near future, where the combination or the synergistic efficacy that's been shown by the induction of DNA damage and the impairment of DNA repair, we could identify such predictors of radiation resistance and select out those who may either be more likely to benefit from radical prostatectomy and save them from having radiation therapy, or consideration of taking advantage of these DNA damage repair with the introduction of a PARP inhibitor along with radiotherapy. Preclinical data suggests that inactivation of homologous DNA repair results in this greater sensitivity to the combination of ionizing radiation and PARP inhibition, and we know that is the case from studies that have been published in the metastatic setting. And we plan in the near future to initiate a phase 1 study which will identify or select out those patients that have identifiable DNA damage repair mutations to look at these in a phase 1 study along with PARP inhibition and radiation to see if we will get ultimately better results in the long run. So my conclusions in general from from high-risk prostate cancer is that we know that the critical ingredients would be dose intensification, and the standard of care is hormonal therapy, androgen deprivation therapy of a duration that is longer, whether it's 18 months or up to 2 years, 28 months, or 36 months. We clearly, and we'll be hearing about that shortly, need better imaging studies to identify those patients that truly have localized disease, whether it's in the salvage setting or in the primary setting as well, to tailor our therapies accordingly. Dose intensification is key, and I alluded to this before, that we need to think about de-escalation strategies in areas where the tumor is not harbored, so we could reduce along the way long-term toxicities. And finally, it's very clear across the board, whether we're using surgery as an excellent treatment or approach for high-risk disease or radiation, we are getting good or acceptable results, but certainly far from optimal. And we need to explore with these approaches the novel targeted and biologic agents, because that is where the future lies for the optimal management of high-risk disease with our local therapies. Thank you very much.